So this next, for those of you who had questions and didn't get to ask them, this is going to be your time, because the next section of the agenda is going to be a facilitated roundtable set of discussions. So you're going to have discussions at each of the tables. I'm struggling with how to do that with this group over here because you don't have a table. And I'm thinking rather than having, 40 or 50 conversations between two people, maybe what we'll do is when we get to the roundtable discussion point is you guys can cluster up into groups of 5 to 8, something like that. The only concern I have is if we have 30 bi-directional conversations going here, no one else might be able to hear anything. The room might just get too loud. So maybe if we can get 5 to 8 people in clusters over here. I'm showing the wrong slide here, but go ahead and go to the first slide. I'm going to start. We're going to use the table clickers. So pick up your clicker. I don't have any particular thing to disclose except that I have been working for a good long while on the assessment toolkits at the AMA looking at the ethical environment of healthcare organizations. So the idea of measuring whether an organization is making it easier or harder for the health professionals therein to do the right thing is something that's been of interest to me for a long time. That may or may not come up later in the discussion, but it's not going to be part of my slides. I also have to disclose that I am a physician, and I tend to think about these things because of where I work and the audiences I typically speak to. I know the history of professionalism for doctors and in the United States. I'm pretty well aware that there are other countries and other professions that are in advance of my thinking on some of these issues. I'm reminded of Winston Churchill's quote about the Americans: "You can always count on them to do the right thing after exhausting all the alternatives." And American medicine is something like that. So I put that on the table as a disclosure. Go to the next slide, please. This is the model of professionalism that we start with. And the next slide shows where I'm headed, which is an understanding of professionalism in context with many other stakeholders in the healthcare system, all of whom have an important voice, right? So next slide, please. So these are the 3 big questions we're going to be talking about at the tables here. One is we're going to discuss some of the inherent tensions of professionalism per se. So not transdisciplinary professionalism, just the idea of professionals coming together to establish standards of shared values and practice competencies. The second thing is, second question is, nope. Back one more. Second question is we're going to talk a little bit about alternatives to professionalism. It's something we haven't really spoken about yet today, but I think is very important to put on the table. Professionalism is not the only way one can organize a healthcare system. So we're going to think for a moment about the other ways in which we might choose to organize a healthcare system and the ways in which these interact. And then third, we'll talk a little bit about the infrastructure necessary. And I think Jody got us off to a terrific start in thinking through what would it actually take to create a transdisciplinary professionalism, not just competencies about teamwork that are shared across professions, but a shared social contract across all of the professions. So now we will go to the first question. And no, that's the second question. First question is this one. And so pull out your clickers. Healthcare professional autonomy means what? Does it mean the right of an individual practitioner to practice as they wish without oversight by extraneous parties, by others? Does it mean the right of professional groups to establish and enforce standards of practice, which, by the way, is in conflict with number 1? Does it mean in some way both number 1 and number 2, or does it mean something else? And I haven't put it up yet. So I'll let everyone vote. When do we close voting? When it looks like there's 15 or 20 people who haven't voted? Those will be our intransigents? Okay. Wow. That's very interesting. Maybe I framed the question in just the right way. So as to get no one to say that professional autonomy means the right of a professional to practice as they wish, to make their own choices without interference by outside parties. No one believes that? Okay. I hear that all the time. Mm-hmm. So this must be a unique audience. Yeah. Yeah, I suppose so. Let's go to the next question. If there were no sense of professionalism among people working in healthcare, number one, high quality care could be achieved using mainly competitive market mechanisms. Or maybe high quality healthcare could be achieved using mainly regulatory mechanisms, establishing standards through regulatory schemes. Or you could get to high quality care through some combination of regulatory and market mechanisms. Or none of the above. We cannot have high quality healthcare without a strong sense of professionalism. Impossible. Depends on professionalism. Or five, something else. It's flashing, but it doesn't seem to be losing any more numbers, so I'll assume we're done. Okay, so we'll go to the results. We have a lot of none of the above. All right, well, this will be a good discussion. So next slide, or next question. This is the third question we're going to be discussing. The most important factor in legitimizing a new transdisciplinary sense of professionalism would be, number one, developing a process, a shared public process for establishing transdisciplinary practice standards. Number two, creating a shared certification program. All health professionals would have a shared certification system. Getting buy-in from the existing major professional associations, that would be the key. Number four, a new professional association. There would need to be a new professional association that would be open to all the health professions, that would be charged with doing this stuff. Number five, developing training competencies and valid assessment tools. We've heard something about that today. Or six, there is some other key step. All right, I think we've got our votes. So we don't like creating a shared certification system. We like transdisciplinary training and a shared public process for setting professional practice standards. Okay, well, let me spend just a couple minutes talking about the first question, and then we're going to break out into the groups. So what does professional autonomy mean? Is this going to be a good way to signal next slide? Okay. I just love this, but I have a seat. What I'm about to tell you might come as a big shock. I'll let that sink in for a moment as you see the X-ray picture of Kermit. So here are a couple definitions of profession that I think are useful, and Fred has already gone through some of this history, so I'm not going to reiterate what he said, but just to note the importance of groups in this and in the next one here. These are both attorneys, by the way, so not specific to healthcare professions. But the idea of groups coming together and establishing standards. And Herb Swick, likewise, although, as Fred noted, very specifically focused on individual behaviors, was nevertheless very interested in this idea of trustworthiness. So not merely trust between the clientele or the public and the profession, but that the profession in some way became worthy of that trust, that professionalism was the process through which one became worthy of the trust of patients and the public. This shows up as well in the ABIM's Medical Professionalism Project, and I think this in some ways exemplifies this line of thinking around here's how we make sure we're worthy of trust. We put forward a set of practice standards, we make them public, and we list them out as specific behaviors that we're then going to hold ourselves accountable to. Now, the challenge here is that these are lists of desirable professional attributes. And it's really important, I think Jordy has already mentioned this a couple times, it is very important to have explicit lists of desired professional attributes. The problem is, although these are important lists because they are critical for behavioral assessments and for training, they are not professionalism per se. So the next piece of this, I'm pretty convinced that professionalism isn't the list of things we say we're going to do. It's the reason why we develop the lists and live up to them. So this is what brings me to the way in which the ABMS and I personally have thought about professionalism over the years, which is to say, etymologically. So professionalism starts with to profess, to speak out, to publicly declare. So a profession is a group of people coming together and speaking out, making a public declaration of the shared standards and values that govern their work, the work of people within that profession. So professional is, as an adjective, it's an individual member of the group or an act or behavior that's in conformance with the articulated standards and values that are shared across the entire group. So a professional behavior is what is articulated in the ABIM Foundation's work and in SWC's work and so on. Professionalism is an ism, like communism, or capitalism, or socialism, or cynicism, or Protestantism, or Catholicism. It is a belief system about how the world works or how it ought to work. It's a belief around the role of professions in delivering an important social good service, in protecting an important social value, right? So professionalism is the belief that professions are the best way to organize and deliver healthcare. And there are a variety of reasons why people believe this, and I'll touch on those in a moment. But I want to just note, to get our conversation started about professional autonomy, that establishing shared standards and values to govern our work and ensuring our shared adherence to our shared promises sets up a series of important tensions. So the AMA ran into this within a decade of its creation in 1846-47, where they set up a series of committees to set practice standards. And yet, in the Code of Medical Ethics, they say, no tribunal other than the physician's own conscience will adjudge penalties for carelessness or neglect. So they're trying to have it both ways. Here are the standards, but really it's up to you as an individual to decide whether you want to live up to those standards or not. And this leads me to my kickoff quote from Captain Barbosa, who said, the code is more what you'd call guidelines than actual rules. So here's the question for your table discussion. To what extent should individuals joining the health profession, and I'll assume for the moment that we're now talking about some kind of a unified sense of a health profession. I don't expect you all to buy that right now, but I'm going to make that assumption for the purpose of this discussion. To what extent do individuals joining a health profession give up some of their personal liberties in order to adhere to shared promises and oversight from within the group? And this issue of shared accountability is going to come up, I think, repeatedly through our conversations. And what we'd like is for each of the tables to spend about 4 or 5 minutes discussing this and finding an example that you'd be willing to share with the rest of the group. We're looking for good examples for us to chew on later. Okay? So we'll break now for 5 minutes of tabletop discussion.